Breast reconstruction is personalized surgery. It's a very personal decision. Every woman will have different goals and priorities, different ways of approaching their decision, and their own hopes and dreams for the future. What matters is that you have access to the information that helps you make the decision that's right for you. My name is Dr. Joe Dusseldorp. Many of my patients call me Joe or Dr. Joe. I'm an Australian reconstructive plastic surgeon based at Chris O'Brien Lifehouse in Sydney. I specialise in both immediate and delayed DIEP flap breast reconstruction after mastectomy. I perform these procedures at Lifehouse and a number of other hospitals. I spend a lot of time listening to women who have had mastectomies or are facing the daunting prospect of a mastectomy tell me what is important to them, what their hopes are for the future, and how they want to live their lives after breast cancer. And I'm convinced we could do a better job at achieving these goals for women, which is why I'm actively involved in research efforts to constantly improve the surgical outcomes we can offer women for their breast reconstruction. I'm committed to tackling some of the as yet unsolved issues like numbness of the breasts after mastectomy and ensuring optimal core muscle function after harvesting the DIEP flap from the tummy area. I'm also convinced we could do a better job at ensuring women have all the facts before they make a decision about their breast reconstruction pathway. And so this educational series is part of my efforts to educate and share information with women who may be considering a mastectomy or who may be just curious of what they may need to know if they or someone they loved ever developed breast cancer. In this educational series, I'll be answering all of the most common questions I get asked on a daily basis about DIEP flap breast reconstruction when I meet women in my clinic. Some of these women have just found out that their treatment could involve a mastectomy, and they want to understand their immediate options. Some women had a mastectomy many years ago with flat closure or breast implant reconstruction and have decided it's time to revisit the idea of a DIEP flap. Others may have only heard of implants as a means of reconstructing a breast and not know that there are other options out there like DIEP flap. Other women may be taking proactive steps to address the genetic risk of an inherited BRCA gene mutation by deciding to remove their breasts in a risk-reducing mastectomy. Whether you can relate to one of these scenarios, or even if you are just curious about what the latest advancements in breast reconstruction may be, my goal is that this educational video series helps you to make sense of what can feel like a very complicated topic and perhaps help you to ask informed questions of your own medical team. Most importantly, my goal is that this series gives you some hope. Hope that your breast reconstruction journey may not necessarily be the awful experience you have been dreading since hearing the mastectomy word. In order to explain all of the various scenarios that can arise in breast reconstruction, I'm fortunate that so many women who have been through this process have volunteered to share their photos and stories with you. Importantly, all of these women have different body shapes and sizes and different goals, because breast reconstruction is extremely personal. What's right for one woman may not suit another. And hopefully through demonstrating this variety, it may help you or someone you know to understand your own goals and options a little better. I believe the most important factor to a successful breast reconstruction happens well before any surgeon picks up a scalpel. What is most important is that you feel empowered to make an informed choice through shared decision-making with doctors and surgeons you trust, who take the time to understand your priorities, your goals, and your hopes for the future. Remember to always consult a FRAX-qualified surgeon, seek a second opinion, and talk to other women who have lived experience of the process. Many decisions about your breast cancer treatment feel like they are outside of your control. But if a mastectomy is involved in your treatment plan, you should be encouraged to at least consider breast reconstruction options. Your reconstruction could be immediate, which is at the same time as your mastectomy, or it can be delayed, which means at some point afterwards. Mastectomy is a loaded word, and later on I'll clarify what the different types of mastectomy are. But it's important to know that the part of the breast that needs to be removed to reduce the risk of cancer spreading or returning is the gland, the inner lining of the breast, not the skin or even the nipple or the areola on the outside of the breast. And so once these areas are preserved, we can then perform DIEP flap breast reconstruction on the inside of the breast, returning that filling to the breast and making the breast whole again. We can also use an implant to fill that space. Or you can have a flat closure you don't have to have breast reconstruction, as we mentioned. So the three options that I would like every woman to understand before they heard the word mastectomy is that the three options are a flat closure, implant-based reconstruction, or reconstruction with their own tissue using a flap option such as the DIEP flap. So what is the DIEP flap? DIEP literally stands for Deep Inferior Epigastric Perforator Flap. And this is really the name of the blood vessel that keeps the tummy tissue alive, the deep inferior epigastric artery. It's a set of blood vessels in your lower abdomen that run through the six-pack muscle. And the DIEP flap is the tissue in front of the abdominal wall, the fat and the skin that enable that tissue to be moved from the abdominal area to the breast cavity, or the pocket underneath the breast skin, and rejoined using microsurgery. The DIEP flap is different to the tram flap, which is an older operation that used to also take the abdominal muscle with it. And importantly, we're taking steps to leave as much of the abdominal muscle intact when we do the DIEP flap operation, preserving not just the muscle, but also the nerves that nourish the muscle and the blood vessels that nourish the muscle, so that the abdominal wall can be as strong, perhaps even stronger in some cases than it was before the DIEP flap operation. In this diagram, you can see that there are two layers of blood vessels that supply the tissue in the abdominal area. You can see the deep inferior epigastric perforators, and they travel through the muscle up to the fat and toward the skin. You can also see the superficial vessels that travel just below the skin surface. This is called the SIEA rather than the DIEA. That's the superficial inferior epigastric artery. And so some patients are actually candidates for the SIEA flap as well. In order to understand better how the DIEP flap tissue could be moved to the from the abdominal area to the breast, I'd like to show you a brief animation that explains this. In this animation, we will identify the different donor sites that there are in the body that can be used for breast reconstruction. You can see the abdominal area, which is the DIEP flap, the medial thigh, the back, and the buttock are the areas that can be used. And each of these areas has an acronym. Latissimus dorsi being the muscle in the back, DIEP, as we've mentioned before, the gluteal artery perforators, superior and inferior, and the transverse upper gracilis flap from the medial thigh. We'll focus more on DIEP flap because probably around 90 to 95% of all breast reconstruction using the own tissue uses this option. It really involves taking the skin and the fat that sits in front of the abdominal wall and using it to replace the filling of the breast after mastectomy. So in this animation, we're doing a skin-sparing mastectomy where all the skin of the breast is preserved, but the nipple and the areola are removed. And you can see the pocket that's left behind of skin is missing the volume and the filling from inside. And so this animation shows using the fat and that little bit of skin that's in the center of that tissue to make the new breast gland and the new nipple areola complex. And this animation shows taking blood vessels from the side of the chest wall. These are the thoracodorsal vessels, but equally it will later show taking vessels from the inner part of the chest wall between the ribs, the internal mammary vessels, which is our usual preference. These blood vessels are rejoined and the tissue is placed inside the pocket that's left behind after the mastectomy to reconstruct the breast. You can see how the blood vessels are brought together and sutured using microsurgical techniques. Once the breast reconstruction is complete, we then turn our attention to the abdominal area, stretching the skin from the abdominal wall down and closing it so that the scar can sit low just above the pubic area, but it does run from hip to hip, as you see here. The final step is to reposition the belly button so that there is a natural abdominal contour to the abdominal wall. And this animation is courtesy of the North Bristol NHS Trust. So I hope that animation has helped you to understand how a DIEP flap operation works, because conceptually it is a difficult concept to understand. And more importantly, what I hope this educational series will help you to understand is whether this is the right operation for you. And that is not just an anatomical decision, but also a decision on how you want to live your life after breast cancer.